Okay, good afternoon. Welcome to Pediatric Grand Rounds. I have the honor of introducing Dr. Loreta Bidot, who's one of our stellar senior pediatric residents. She's going to be speaking on the topic of caustic ingestions, not injections today. Dr. Bidot is a graduate of the American University of the Caribbean School of Medicine. She, during her time here at ETSU, has received a number of times the award for Resident of the Month. She was also this year nominated for a Caduceus Award by our third-year medical students for her excellence. She has done quite a bit of work on projects and presentations at conferences, 2 full pages of abstract publications and presentations. And she is moving to Miami after graduation and has a job doing outpatient general pediatrics. So we are all going to want to go visit her. So without further ado, Dr. Bidot.
Thank you very much. Welcome all to Grand Rounds. My name is Loreta Bidot, and I'm a third-year pediatric resident at ETSU. First and foremost, I would like to disclose that I have no financial interests, unfortunately. And I will start my presentation by telling you all a personal story. When I was around 4 years old, I was under the care of a babysitter at home, and I, like any curious 4-year-old, I found my way to underneath the sink, and I found a bottle of kerosene that we kept down there for different purposes. Some people use it for cooking purposes. It's used in oil lamps. Is used to fuel jets. So I opened it, and my babysitter found me with the bottle in my hand. She was not sure whether or not I had consumed any of it. She immediately contacted my parents. I was rushed to the hospital. They did a gastric lavage at the time, and they concluded that I probably had not actually drank from it, that I had probably just inhaled some of it. And subsequently, I didn't have any issues or complications. I was observed in the hospital for a few hours and then sent home soon after. And that's just one of thousands and thousands of stories of accidents of this type that occur on a daily basis in households. And like you all might already know, I will be discussing caustic ingestions. I will start my presentation first by discussing kind of a historical perspective on caustic ingestions. We'll talk about the different types of ingestions, the pathophysiology behind it. We'll talk about management, initial and long-term. We'll talk about complications due to ingestions, what current research says about this. We'll have some conclusions at the end, hopefully some time for questions and references. So discussing the background, towards the end of the 19th century, the beginning of the 20th century, there was an introduction of sodium hydroxide products that became available for household products. And there was a significant increase in reported accidental ingestions by children at that time. Chevalier Jackson, who was an ENT actually, in 1910 published the first 4 cases of sloughing of the esophagus due to proprietary preparations. And he became one of the pioneers on caustic ingestions. Due to his research in the year of 1927, there was the Federal Caustic Act, which required all toxic products to have a label on them that would warn people about their toxicity. After that, in 1953, the poison control centers were developed, and this was a place where people could call in and have all kinds of information regarding different products. In the 1960s, the Federal Hazardous Substance Act was put in place, and this required labels not only on other types of toxic products, but specifically on household products. And later on in the 1970s, there was the Safe Packaging Act, and this is what we all now know as child-proof bottles, and this became also due to all this increased reported ingestions from children. Despite all these precautions, on the 2014 annual report of the American Association of Poison Control Centers, they still report about 79% of the calls to the Poison Control Center are due to ingestions. So it's still a pretty significant burden to our society to, despite all the prevention, to have these accidents happening. And going further into more detail from the poison control report, we're focused more on the pediatric group, which was this center table right here, which are children less than 5 years old exposures. 15% of them were due to cosmetic or personal care products. 11% were due to household clinic substances, which is mainly what we're going to focus on today. And then furthermore, there's analgesics, foreign bodies, topical preparations, vitamins, antihistamine, pesticides, GI preparations, and plants. Over 200,000 ingestions of cleaning solutions per year are reported to poison control. About 100,000 of them are mainly children below age 6. 5,000 to 15,000 are due to caustic ingestions, a majority of which come from household cleaning solutions. 10% of these ingestions can result in severe injury. Out of those, 1 to 2% will develop esophageal strictures, which is one of the main complications, and 40% of caustic ingestions will involve the larynx. It's also important to note that there's a bimodal distribution of ingestions. We talked about the less than 6-year-old children that mainly are due to accidental ingestions. When you go into the adolescent or adult side, these are more of an intentional thing. They're more due to suicide attempts or self-harm. They usually tend to ingest larger amounts of the substances, which in turn causes a more severe damage to the esophageal mucosa. Like I mentioned before, most ingestions are accidental in children. Teenagers are also a risk, but ingestions at this age are usually more purposeful and with the motive to self-harm. Now we're going to go back a little bit into organic chemistry, and I hope nobody runs out of the room, but this is a pH scale. I'm sure you'll remember. pH less than 7 is what we call acidic. Greater than 7 we call alkaline. The stronger acids are of pH less than 2, and those can cause most of the damage. Alkalis greater than 11 are strong alkalis, and those can also cause pretty significant damage. And why is this important? When you're initially evaluating the patient in the ER, it's important to know what kind of substance you're dealing with. It can tell you about the extent of the injury. It can tell you about how to manage the patient. It's also important to know that bleach is around 7%. The pH is around 7, which puts them more of an irritant category, so it doesn't cause as severe damage as the other two. And like we mentioned before, alkalis are, I'll put the mic on. Sure. Sit down.
Go ahead. Continue talking.
I can continue? Okay. And like we mentioned before, there's different types of injections. You have alkali, pH greater than 7. Usually the damage is caused by liquefaction necrosis. Thank you.
Sorry.
It's okay. Thank you. Can you hear me now? That's good. Okay. All right. Acidic substances with a pH less than 7 will cause coagulation, necrosis, and bleaches, like mentioned previously, are neutral pH, and they cause mainly irritation. The severity of the tissue injury takes into account many different variables. Among them is the pH, like we mentioned, the concentration of the substance, and the amount consumed, as well as the length of time of the substance with the mucosa. It's also important to note that liquid versus solids can cause different types of damage. Liquid products tend to cause more distal injury, whereas solid products tend to cause more proximal injury to the oral cavity, and it's not necessarily distal to the esophagus or to the stomach. What kind of symptoms do this kid present with? The symptoms vary significantly and include some of the following, but it's not limited to: dysphagia, drooling, feeding refusal, chest pain, abdominal pain, vomiting, hematemesis, stridor, hoarseness, nasal flaring, and retractions. One of the challenges taking care of this type of patients is that many studies have shown that the presence or absence of symptoms is not an accurate predictor of whether a caustic ingestion has actually taken place or if any serious damage has occurred. And the presence or absence of oral burns is a poor indicator of esophageal or gastric injury. One of the studies, after reviewing the literature, showed that a single series of 378 caustic ingestions in children, 12% of them had no symptoms but had severe esophageal burns, whereas 82% who were symptomatic at presentation had minimal to no esophageal involvement. In a review of multiple cases series totaling 489 children, 45% without oral burns had esophageal burns, and 54% with oral burns had accompanying esophageal burns as well. So that's one of the main challenges we face. Now going more into detail about alkali ingestions, there's an estimated 68% of cases of alkaline ingestions reported. These are some of the few household products that are commonly used, include drain cleaners, dishwasher cleaners, over cleaners, laundry detergent, ammonia, hair strainers or relaxers, and many other household products. Disc batteries are also part of this group. I'm not going to focus too much on that. That will be a separate topic to discuss, but we're going to talk more about all the other products. A new danger, which this has come up in the last few years, are the concentrated laundry detergent, such as the capsules, the gel packs, or pods. These have caused an increased concern in the last few years. These products are usually very small, they're colorful. I don't know if you can tell, some of these are actually laundry detergent or dishwasher detergents, the ones with a little star. And they look like candy, so kids love to get their hands on them and try them out. So in 2012, the AAPCC issued a safety warning about this type of product to try to educate parents to keep this type of products away from children because they were seeing an increase of reported cases of ingestions. So how do alkali ingestions damage our esophageal mucosa? So the damage is caused via liquefaction necrosis. And how does this happen? Once the substance becomes in contact with the mucosa, it causes disintegration and allowing deep penetration and even perforation of the esophagus. How fast does this happen? It depends on the concentration of the fluid. So 10% of sodium hydroxide may require about 1 minute to produce a deep burn, versus 30% of sodium hydroxide can cause transmural esophageal necrosis within 1 second of being in contact with it. Liquefaction necrosis involves saponification of fats, denaturation of proteins, and disruption of the cellular membrane, allowing for alkaline substances to diffuse into the deeper layer of the mucosa and cause severe damage. Small vessel thrombosis and heat production can also occur during this time. And like I mentioned previously, agents with a pH greater than 11 cause the most damage. Liquid form bases are tasteless and denser than water, which can result in most distal injury to the esophagus. And usually when kids ingest these substances, they don't taste bad, so they just keep drinking it, which can lead to further damage and worse outcome. And this is an image showing injury to the larynx and the epiglottis after ingestion of an alkaline material. And you can see already some of the changes in the mucosal surfaces occurring. Following the initial necrosis caused by the ingestion of the alkaline substances, there's further destruction that happens of the tissue, which continues due to inflammation and vascular thrombosis for several days. After 2 to 3 days of the ingestion, the granulation tissue begins to form, and during this time, the tissue becomes very weak and vulnerable to perforation. Collagen deposition and fibrogenesis starts occurring around 2 to 3 weeks after the initial ingestion. As the scar tissue thickens, it can cause strictures, and that's one of the major complications after an ingestion. You can have superficial burns that result in strictures in less than 50% of cases. However, when you have a full thickness burn, you can have a stricture in nearly 100% of the cases. Severe burns can be associated with esophageal perforation. Now, if we go to the other type of ingestion, we move on to acidic ingestions. And some of the common products that have lower pH include toilet, bowl cleaners, battery fluids, swimming pool products, rust removers, and drain cleaners. Acids can cause tissue damage to coagulative necrosis, so it's a different process than the alkali substances. And the pathophysiology and the mechanism of injury is different. Once the acid becomes in contact with it, you usually form an eschar, which is thought to prevent the acid from penetrating into the deeper layers of the mucosa, which is different from how alkaline substances work. And while the eschar may be partially protecting the esophagus from deep burn, acid tends to pull into the antrum of the stomach and can lead potentially to gastric perforation or pyloric obstruction. Acids with a pH less than 2 are usually very damaging to the tissues. Unlike alkalis, they tend to taste bitely and are irritating. So most children will start choking or gagging on it, which can lead to aspiration of the caustic material and airway compromise. Delayed injury, so after the initial damage, whether it's caused by an alkali or an acidic substance, there's additional destruction that takes place over the next few weeks, mainly caused by inflammation and vascular necrosis. By 10 days, there's the formation of the granulation tissue that we talked previously, weakening of the esophageal wall, and during this period, the esophagus is increasingly vulnerable to perforation. By 3 weeks, fibrogenesis and stricture formation are well underway, and perforation is less likely. Gastric injury, like we mentioned before, usually occurs with, can occur with both. It's less common than esophageal injury. It's mostly seen when they ingest large volumes. Among patients with acidic ingestion, gastric injury is most severe, like we mentioned before, due to the pulling on the antrum of the stomach, which can lead to pyloric obstruction. So what do you do when you first see a patient after a caustic ingestion. So the most important step is to identify the location, extent, and severity of the injury. It has been shown that clinical and radiological evaluation alone do not predict the type of severity of injury. Endoscopic evaluation has become a mainstay in assessing burn injuries, typically performed between 12 to 48 hours after the ingestion. So during your initial evaluation, your history should include the timing of the exposure, the estimated amount ingested if it was observed by a caretaker, the exact type or brand of the substance ingested, the pH if it can be measured or determined from the material safety data sheet, or you can always call poison control, and this is a good number that everybody should be aware of. It's 1-800-222-1222, and you can always call them, tell them, my patient ingested this substance, what do I need to watch out for, and they will give you all the information. In your initial evaluation, you want to initially assess their mental status, their vital signs. You want to look at their pupils to evaluate for central nervous system excitation or depression. You want to evaluate closely for respiratory compromise, including the presence or absence of stridor, hoarseness, nasal flaring, retractions, and wheezing. Drooling, food refusal, and complaints of dysphagia suggest oropharyngeal and esophageal injury. The lips and oropharynx should be inspected thoroughly for burns. However, as mentioned previously, the absence of oral burns is a poor predictor of esophageal injury, and you always have to keep in mind as well the possibility of multiple ingestions. Like mentioned before, you always stabilize your airway breathing circulation. You make sure the patient is stable. Then you perform your secondary survey, and this is mainly in the ER when you do a complete head and neck exam, including a fiber optic laryngoscopy if the patient is stable. After that, imaging can be helpful at times. A chest x-ray is always appropriate in any patient that has respiratory symptoms. You can rule out any foreign body ingestion. You can look for pneumonia, as well as complications due to the ingestion, which could lead to pneumomediastinum caused by perforation. You can get a KUB, and that will help you rule out gastric perforation. Radiographic contrast studies, such as an upper GI series, is generally not used on the initial presentation. If contrast is needed for whatever reason, you want to use water-soluble contrast rather than barium on initial presentation. On follow-up evaluation for these patients that will require contrast studies, and after the initial presentation, when there's no known perforation, you can use barium to follow up and look for strictures on these patients. As far as laboratory studies goes, many studies have shown that labs will not have any consistent predictive value of gastric or esophageal injury. One lab that you may consider doing in the ER is an ABG. You can assess for any metabolic component of the injury, but most labs won't be helpful initially. How do you manage these patients? Mainly as supportive management, close observation and emphasis on preventing vomiting, choking, and aspiration. In the past, there was thought that inducing emesis was a good thing to do. Current research has shown that this is contraindicated. You can cause further damage to the esophagus. You can cause aspiration and further complications. And like I mentioned in the past, ipecac-induced emesis was used. That continues to decline in the last 2 decades. The AAP recommends that ipecac should no longer be used routinely as a home treatment strategy. Activated charcoal is still used, but also has been declining in the last decade. From 1993, about 3.7% of kids were giving activated charcoal in the ER after ingestion. In the report in 2014, only 0.8% of the patients received charcoal. And this gives you the table from the Poison Control Annual Report. And this mainly the therapy provided in all the different exposures, focusing on children less than 5. Most of them were given some kind of dilute agent. They were given food just to try if everything was fine. They were tolerating it well. 76% of them were given multiple doses of charcoal. 7,900 of them given one single dose. And you can tell down here there were still some patients that were giving Apicac, even though it's not recommended. On this table, you can see the decrease. The 0.8% that I mentioned previously comes from this number. It's around 0.77, which is the decrease from previous years. And here, I mentioned it briefly before, neutralizing agents are also not recommended due to the concern for additional damage from heat injury during the neutralization process. It's been thought that giving milk or water after the ingestion can help, but you can distend the stomach, cause further vomiting, and that can cause further damage. So also, there's lack of efficacy on this type of management. So what do you do if you see a patient that's asymptomatic? If there's no evidence of oral lesions, no dysphagia, no vomiting, or other symptoms, you can watch them, observe for several hours. You can monitor for fluid intake, make sure the overall status does not deteriorate, and you can send them home after that. However, if the patient is symptomatic, you definitely want to admit to the hospital for close monitoring. Those with significant airway compromise may require PICU intubation and or tracheostomy. All symptomatic patients should be evaluated with an open endoscopy unless otherwise contraindicated due to respiratory compromise. Now going into the topic of endoscopic evaluation. Ideally, it should be performed at 12 to 24 hours after ingestion. And this number has changed in the last few years. In the past, it used to be thought that waiting 24 hours was what was most beneficial, and doing it less before the 48 hours was most beneficial. Most research, current research, shows that between 12 to 24 hours is the ideal time to do the endoscopy. And this will give you further information. It will tell you the extent of the injury. It can predict prognosis, and it can guide your management for these patients. Like I mentioned before, the timing is crucial. If you do it too early, before the 12 hours, you may not be able to visualize the full extent of the injury. And if you do it 4 days after the ingestion, you have an increased risk of perforation because the mucosa has thin and there's granulation tissue forming, and you can cause an iatrogenic perforation. Now going back to anatomy for a few minutes, and this is important for the staging of the damage caused to the mucosa. The esophagus has 3 primary layers, and med students will probably remember this better than all of us. You have the mucosal layers, which is the innermost layer, which consists of squamous epithelium, lamina propria, and muscularis mucosa. The second layer is the submucosa, which is a deeper layer, consists of fibrous connective tissue with blood vessels, nerves, and mucosal glands. And then the last layer is your muscular layer that's divided into the inner and outer muscle layers. Like I said, these anatomic layers are important because most of the staging systems in the literature are based on findings seen on endoscopy that correlate with the depth of the injury. These are one of the stages that's mostly used. Grade 0 is your normal mucosa. Grade 1, you'll have mucosal edema and hyperemia. Grade 2 is further divided into 2A and 2B. It mainly shows friability of the tissue, hemorrhages, erosions, blisters, and ulcers, whether they're superficial or deep. In 2A, you will have no deep focal or circumferential ulcers. They're just superficial. And 2B, you'll have deep focal and circumferential ulcers. Grade 3 is further divided into 3A and 3B. 3, you'll have multiple ulcers and you'll start showing evidence of necrosis of the tissue. 3A, you'll have small scatter areas of focal necrosis, and in 3B, you'll have extensive necrosis of the tissue. As far as management is concerned, it's also controversial. In the past, there was a thought that steroids will be useful, and most recent research has showed that it could be potentially beneficial in patients that have respiratory symptoms. They should always be given in conjunction with antibiotics, not on their own. And high doses for several weeks can definitely cause further complications. You put the patient at risk for infections. And there's still multiple studies out there reporting that after the use of steroids, there's no decrease on stricture formation, there's no decrease on prognosis of the patients. Antibiotics, on the other hand, are used mainly on grade 2 injuries or greater. However, no control studies have also been done with antibiotics. It's also controversial his use and whether or not they're beneficial. During your management, you can use PPIs, which decrease your acid production. One of the studies that I read showed that decreasing the acid may delay the formation of the healing of the esophagus, which could potentially not be as beneficial. And one of the main topics that is important to talk about with these patients is their nutritional status. Imagine having all your esophagus or your stomach burned. You won't be able to eat anything by mouth. So having an NG tube place or TPN to make sure that the patients stay in a good nutritional status is also very important. Some of the complications we see with caustic ingestions, like I mentioned in the past, esophageal perforation is one of the ingestions. Strictures are actually the most common one seen, but esophageal perforation can lead to mediastinitis, esophageal fistulas, or major vessel fistulas. Gastric perforation can lead to toxic shock or septic shock that can lead to peritonitis and hemorrhagic pancreatitis. And we talked about this a little bit. We talked about stricture formation. We talked about pyloric stenosis, especially with acids, and that acid pooling into the antrum of the stomach, leading to stenosis. And one of the bigger concerns is esophageal cancer. Patients after an ingestion need to be in surveillance for a significant amount of time due to the potential for the development of cancer. There's the increased risk for esophageal cancer is reported between 1,000 to 10,000 times higher in this population than in the rest of the population. And some articles actually recommend annual barium swallow in patients that have had grade 3 injuries or severe esophageal strictures to monitor for the development of cancer. Some of the articles that I reviewed, this article was published in the ENT Head and Neck Surgery in 2015. It was titled Caustic Esophagitis in Children, Prevalence, the Corrosive Agents Involved in Management from Primary Care through Surgery. And their conclusion from this study was that unfortunately neither dilatation treatment or esophageal bypass surgery can prevent the development of esophageal carcinoma, the incidence of which is higher after a caustic substance ingestion. The continuing unacceptably high incidence of ingestions accidents could be reduced if corrosive materials were sold in their original child-proof containers, highlighting the need for preventive and adult education programs. As far as long-term management for these patients, they will have scar formation that can lead to narrowing of the esophagus, causing strictures, which will require serial dilatation of the esophagus. Most recent studies have shown some preliminary results using mitomycin C, which is a fibroblast inhibitor, and this has shown the prevention of recurrent stricture formation. It was a preliminary study. There's not a lot of literature on it currently, but it seems promising for these patients. These patients will also have a lot of motility dysfunction due to the damage of the myenteric plexus. And like I mentioned previously, they will need long-term endoscopic surveillance due to the increased risk of carcinoma. And this is another table from the poison control annual report. And you can see, and this is mainly in just pediatric population, children less than 5. Out of all the substances, cleaning substances or household products are on the second place. There's about 100,000 case reported, and you see some of the other substances that were reported to poison control. In this one, these are ingestions leading to death, and you can see again cleaning substances, household products are also in the top 5, and there were 7 cases reported of death in children less than 5. This is one of the examples that they reported. This actually summarizes what the table says. Although children younger than 6 were involved in the majority of the exposures, 34 of them led to fatalities, which is similar to those reported since the year of 1985. So things have not really changed much despite all the preventative measures that we've tried in the last few years. As far as adolescent fatalities, the age range was 13 to 19 years. There were 61 case reported fatalities, and that was a decrease of 3 from 2013. And those included, like I mentioned before, mainly non-accidental ingestions. So 54 of them were intentional, 4 were unintentional, and some of the others were unknown. And the substances involved are also different types than younger children. And in summary, this is a treatment algorithm of caustic ingestions. Symptomatic patients will need an endoscopy done. And here it says 24 to 48 hours. Most recent research says you don't need to wait 24 hours. You can do the endoscopy between 12 to 24 hours. Over here, you can see if the ingestion is questionable. You can observe, you can offer clear liquids, observe for 2 to 4 hours. If the patient remains stable and asymptomatic, they can go home, and if they develop dysphagia at any point, they will need an upper GI series to look for strictures. However, if the ingestion is definitely, and the patient doesn't have symptoms or it has moderate symptoms, you will want to do an endoscopy. And depending on the degree of injury, then you'll proceed to further management. Definitely, if the patient has severe injury and severe symptoms, you want to do an endoscopy right away under general anesthesia. And at that point, you will consider putting an NG tube, gastrostomy tube, some type of nutrition support for the patient. And they will need upper GI series in 2 to 3 weeks after the ingestion, and dilation as needed to prevent the formation of strictures. This was a case that is actually a bleach exposure, but it was reported on the poison control article. It was a 17-month-old female that removed bleach from under the sink and poured it on herself. Her mother found her crying in a puddle of bleach and reported that the child's skin peeled off as she was cleaning her off with a wet towel. After initial evaluation in the ER, she was found to have second-degree burns to the perineum and legs with minimal lower leg involvement. She had extensive burns of the lower back and buttocks. There were no splash markings noted. No irregularities consistent with clothing were noted. The child developed pseudomonal sepsis and died on day 3 after hospitalization. The autopsy finding show extensive excoriation, more than 30% of the abdomen, back, pelvis, and lower extremities. Macroscopically, the tissue showed thermal burns with complete necrosis of the epidermis, and the cause of death was pseudomonal sepsis. The medical examiner determined the manner of death to be accidental due to dermal bleach burns. Some of the key points for today, take-home points. Caustic ingestions continue to be a significant problem. Endoscopy is the primary method for evaluating the severity of the injuries. Strictures is the main complication following a caustic ingestion. Evidence-based treatment protocols to prevent strictures are still lacking, and caustic ingestions can lead to esophageal cancer. And in conclusion, as with most accidents, prevention is the best form of treatment. Unfortunately, sometimes we cannot protect our patients from themselves, and there's no reliable relationship between the physical examination findings and the actual mucosal tract injury. Like I mentioned before, alkali agents cause liquefaction necrosis, acids cause coagulative necrosis. Endoscopy is the gold standard, and you want to do it in less than 24 hours after the ingestion. Barium swallow should be done in patients presenting after 48 hours, as endoscopy generally considered contraindicated for risk of perforation. With patients with esophageal burns, they need to be followed throughout the lifetime for stricture formation as well as increased risk for esophageal cancer. And that will be all. Any questions? Yes.
I heard on the news today that essential oils are rising, and so does the poison control coming out and saying essential oils are rising as far as the cause of ingestion and poison control center. Do you know if those are caustic or?
I have not read anything on essential oils. The last report that I saw from the poison control was 2014. So if this is something that's happened in the last couple of years, that it will probably be on the next report they'll have out, probably in the next couple of months. But that's interesting. Yeah. Yes. Yes. It was, yeah. That was in the 80s. So it was myself who actually ingested it. So it was me. I was under my babysitter's care, and I made my well under the sink, and they thought that I probably didn't ingest it, that I probably just inhaled it, but it was in the 80s, so they did a gastric lavage, and they watched me in the ER, and then they sent me home. I think I'm fine. I think I'm okay. Any other questions? Well, thank you so much for your attention. These are some of the references that I used. And this is my puppy. Thank you.